can hear now. Great. All right, so our online community has joined us with audio now, so they can hear us, so that's great. So as I was saying, there's a couple of different types of oncology navigators. Our most common is outpatient navigators. We can have site-specific navigators who are dealing with a particular type of cancer, or there can also be navigators who are care-specific. You can find oncology screening navigators, and you'll see that more often in lung cancer screening because of determining eligibility and the annual follow-ups. But their process is quite a bit different from what your cancer care navigators are doing. So next slide, please. So what is an oncology nurse navigator? I like this definition, so I kind of wanted to share it tonight. A nurse navigator is a medical system advocate, and they help patients and their families understand each part of the cancer journey while compassionately supporting physical, emotional, and spiritual needs. As a nurse, I think this is closely aligned with the definition of a nurse, but a nurse navigator is given the unique opportunity to focus on these aspects of patient care and interaction, which are just as important but separate a lot of times from the clinical area of patient care. So we're a proud group. We like that what we do, and we think it's important, even when it's not about starting the chemo and giving the injection and those type of things. The whole person in the cancer journey needs to be treated, and we provide a valuable service for that. Next slide, please. So let's talk about the nurse navigation process. The first step in the nurse navigation process is the referral. And there are some ways that you can get different referrals. Patients come to navigation in a few different ways. Some navigators receive path reports with a cancer diagnosis and begin their process from there. This can be a delicate balancing act because you do not want to reach out to a patient prior to them speaking with their physician about the results of their test or receiving their diagnosis. But the positive side of this process and this method is it gets you involved early and allows you to plan your interaction with the patient around their initial consultation with the oncology team. Another way patients get to navigators is through physician referral. This occurs most often when the navigator lives in one clinic but navigates for all cancer patients. For example, if a navigator is usually in the medical oncology clinic, but the surgeon wants to send breast patients for navigation, there's a process for referral. That can look different in each system, and it's usually dependent on the EMR, but this process will allow the navigator to offer services to patients that might have otherwise slipped through if they were a surgery-only patient. The most common referral process for navigators is to be embedded in the new patient process. In this model, the navigator meets with all new cancer patients at the time of their initial consultation with their specialist. Next slide. The navigator will complete a patient assessment next when they move into this process. Usually through chart review and patient interview, they can also glean information through multidisciplinary care conference. Navigators attending tumor board can be a valuable part of that process. Many times in tumor board, issues arise about patient compliance or understanding of their treatment plan, where a treatment plan can be changed and the navigator then has the inside track on knowledge to acclimate the patient to the change. And once you've done your assessment, then we move on to the interventions. And nurse navigator interventions are most often in the form of referrals to appropriate services. Financial concerns can be identified and referrals made to community resources, or issues with mental health may need to be addressed and a referral can be made to the appropriate provider. As nurses, they can also assist with symptom management and help articulate patient concerns to providers and expedite response to the issue. A patient may not always be able to express their concerns in a provider appointment if they feel they should just deal with it as part of treatment. I think we hear that quite a bit, that, oh, I'm having chemo, I knew I would be sick. But that's not necessarily, that's not true at this point. We should be able to treat that and help them with that. And your navigator connection to your patient allows you to get that information. Navigators are able to have more frequent and longer conversations, and they act as excellent detectives to find out what is going on with the patient and address it accordingly. One of the things, kind of a common issue I think we see in today's cancer patients is, although their age may be older and you may not know that they're raising children, they're raising grandchildren. So you have 70-year-old cancer patients in chemotherapy who have issues with daycare. And in a regular clinic appointment, you may not know that. They may not share that with you, but that's something that the navigator can identify and kind of help alleviate for that patient and find resources for them. And after the interventions and the patient has come to the end of their conventional treatment, the next thing the navigator can do, next slide, is help them transition to the next appropriate level of care. So that can mean a couple of different things. You can provide the patient with information on transitioning to survivorship. They've completed active treatment. They're moving into a phase where their life goes back to some degree of normal. But this could also mean hospice or end of life care. It could mean connecting them back to primary care, for sure. If a patient had a primary care physician prior to their diagnosis, the navigator can connect them back to that provider. If the patient didn't have a primary care provider prior to their diagnosis, they can help them locate one. In survivorship, it's very important to deal with late-term effects of treatment, late-term effects of the disease itself, and get them connected for appropriate follow-up care and screenings for other cancers. At TJ, we have an excellent survivorship program that my friend Melanie runs, and it's great, and we're very proud of it. And we sing its praises all the time, but it's important when those survivorship care plans come back to primary care that you know what those are for. And Amy, as the navigator, helps to make that happen, and she can connect the patients that way. So that is the process for navigation in oncology. The benefits of navigation, and I've covered some of these throughout this discussion, but the things that patient navigation can do is it helps increase treatment adherence, which is so important. It improves health outcomes for cancer patients. By providing the patient with a single contact person they can connect with, they are more likely to reach out and ask questions and report problems. Cancer patients and their caregivers often experience barriers to timely, high-quality cancer treatment, and these barriers run the gamut. They include lack of experience with the healthcare system. We've all had a patient who says, well, I haven't been to a doctor in 30 years. Well, a lot has changed in healthcare in 30 years, so they don't really know how things work, and a navigator can help them with that. Inadequate health insurance. They've never been sick. They've never utilized their insurance in this way, so now they have to learn how to do that. And the navigator can help them. And if you've never, okay, move the mouse. There it goes. Okay. This can provide, let's see, they may not know all the resources that are out there for them. Even if they've lived in the community and heard about them, they may not know how to access them. The navigator can help them with that. Challenges with day-to-day activities such as transportation to treatment and taking time off work. And the needs of cancer patients change and evolve throughout their cancer journey. So if you have a patient who's receiving radiation or chemotherapy, the first month they're in treatment, they can drive themselves maybe. By the second month, maybe they can't. And now if there's no one there to really reassess that and they're not giving up that information, it's hard to address that barrier. In today's world of multidisciplinary cancer care, the navigator can be seen as standing next to the patient, and that's what we see with this diagram. Instead of the navigator being out in the circle of resources, they're kind of there with the patient to help guide them to the connections they need to make those things happen. The benefits to providers by utilizing navigation is care coordination. They can be the clearinghouse for the information to get from one clinic to the other. Anytime we improve adherence to treatment, that's a benefit to the provider as well. And transitioning the patient to the next level of care is important, whether that's up a level, down a level, out to end-of-life care. That transition can be important. Research continues to show that navigators can help reduce disparities in cancer care, increase patient satisfaction, and improve health outcomes, which is what we all want. Oncology navigation is a win-win for patients, caregivers, and providers, and I hope that everyone can take advantage of that for their patient population. Next slide is just for questions. Anybody have any questions for me or statements, Dr. Cerdas?
If the provider, let's say, doesn't consult the nurse navigator or consult the oncologist, will the nurse navigator be brought automatically to the patient's care through the oncology office, or is that separate?
At TJ, is that a yes? Yes. They will automatically be consulted. So, right. Yep.
If they have medical oncology, but if they don't have medical oncology, I may not know about it unless somebody let's reach out and see.
So I think everybody has a copy of my presentation. If you have any questions, or I think they're available if you didn't pick one up, I'm happy to help answer any questions you have. And I guess I can introduce Devin. Is that how we, yes?
Actually, I'm not sure how I get hooked into the navigator.
Okay.
The oncologist always does that?
At TJ and Samson, yes, that's how that works. Amy is the oncology navigator, and Beverly's the oncology social worker, and they are housed in the medical oncology office. So that's how you connect with them here. It's different in different places, and I'm on just kind of an overview, but here at TJ, that's what they do, is you go through medical oncology.
Patients go all over creation.
Yeah.
In oncology.
And most of them will have a navigator that they will see, and that's usually where they're connected at. And sometimes if you have a comprehensive center that has radiation oncology and medical oncology in the same facility, that navigator sees all of those patients, or there's more than one navigator that sees them, but that's usually in your cancer center is where they'll get connected with them.
So I have a chronic care management nurse in my office. Is that her job to just try to get her into that system?
Could be, and that's a similar position to a navigator, to have a chronic care nurse, because they're managing chronic illnesses for the patient and helping them get it connected to the resources that they need. So that she would be somebody who could maybe reach out and find out. But I'm speaking blindly because I'm speaking in generalities, but that's usually the way that can work.
So if oncology see one of my patients here at TJ, then they're gonna get hooked into a navigator.
Yeah, and usually I patients are is that whenever the provider finishes seeing them, they'll meet with the social worker and the navigator that day as well. I also get referrals for patients like through our tumor board. If they're discussing at tumor board, then I will send them out a letter to reach out to them to let them know I exist and how to contact me and kind of what my role is. That way, if they never make it to medical oncology, I'm still here if they need me to help them with any kind of resource or education, whatever it may be. So, coordination of appointments or just whatever. I'm really whatever they need to do. So.
All right. Any other questions? All right. Well, I'm going to turn it over to my colleague, Devin Boland. Devin is a senior social worker at UK's Markey Cancer Center. She's joining us via Zoom tonight, and she's going to talk about utilization and benefit of social work navigation. Devin, it's all yours.
Thanks, everyone. Well, thank you for having me. So I'm going to be talking about utilization and benefit of social resources and navigation. Next slide. All right, so over the objective and my goals are to role of social work, what social work is, our ethics, and role specifically of oncology, offering different types of support that we can, and then discuss the benefits of what a social worker can bring to the multi. Slide. So social work profession. So in America, the social work profession was established at Columbia University in 1898. And initially, sure that immigrants and other vulnerable populations were had access to tools and skills to economic and social poverty. Today, we still, including in oncology. So we do have a code of ethics, and we sort of have, I think, primary pillars of our what we are dedicated to within our code of ethics. And these include service, this, key and worth of the person, importance of integrity, and in Kentucky, typically we are governed by the Kentucky. So there are also organizations. So just briefly here, and I won't get into the nitty gritty of this, this is just sort of a breakdown of what different social work degrees and licenses look like and sort of how those are separated. A lot of the oncology social workers that I work with have CSWs and LCSWs. Essentially what that means is we all received master's degrees. Some of us can offer psychotherapy in an independent setting. Some of us are under supervision and can offer psychotherapy to our patients and caregivers as well. And then nationally speaking, there is a certification for an oncology social worker as well, which is something that I'm working toward, and is essentially you have to provide evidence showing that you've worked in an oncology setting for at least 3 years, have letters of recommendation, all that good stuff. Next slide. So just an overview of what some of the social work skills can look like within the role of oncology. And I'm not going to read each of these as well, because it sounds like you all have access to this presentation. But just some of the things that we can do: facilitating difficult conversations, looking at complex situations, meeting with patients to assess what's going on and meet with them where they're at to help navigate those complex situations and act sort of as an advocate for the patient and the care team. We can offer counseling services to patients and caregivers. We can offer education to patients about different resources and support, whether it be on the community level all the way up to the national level, and then supporting our providers and the multidisciplinary team as well. Next slide. So sort of how that looks like for social work. For all of social work, we have a sort of this standard of how we interact with our clients or our patients. It begins with the engagement stage, where we meet with patients where they're at. We get to know them. We get to know what they're going through, what their concerns are, where it is that they're coming to this place in. And sort of then into that, we begin to assess. What are the needs that are there? What are the concerns that we can help with, whether it be practical things like transportation, access to treatment, finances, whatever that might look like, or emotional concerns as well, whether it be social support, potentially interest in psychotherapy, that type of thing. Next comes the intervening stage, where we introduce those resources. So we connect them with transportation resources, lodging resources, national resources to help connect them with financial assistance, or local resources. Just essentially introducing those resources and support, and then finally reviewing and evaluating that. How did this work? How can we change it? How can we make it a little better for next time? Is it good? And that's sort of just a loop that we continually go through as we're working with patients. Next slide. So next, looking at the types of social work and navigation. So practically speaking, the types of support that we oftentimes provide for families and patients: transportation assistance, lodging assistance, navigating healthcare resources and community resources, offering financial assistance, whether that be with co-pays, or connecting them with local organizations to help pay utilities, even national organizations. And I should have introduced a little bit earlier on as well, although you may know. So I primarily work with our GYO clinic here at the Markey Cancer Center. And so even looking at specific national organizations for my oncology patients, we have specific ovarian cancer national resources that I often connect patients with, and have relationships with the members of those organizations so I can help facilitate that. Practically speaking, even offering wigs and head coverings or education on SSI or SSDI if they find that income is going to be a concern, depending on the length or diagnosis of what they're encountering. So, next slide. So in terms of psychosocial resources, so this is what I think of as more of our emotional support throughout care. So similarly to Sabrina, we are meeting with our patients where they're at. We are able oftentimes to spend just a little bit more time with them because we know that their providers are on a super busy schedule. And so getting to provide that support in clinic, coordinating psychotherapy, whether that be in-house at Markey, that is a service that we're able to provide to our patients and caregivers, or connecting them with resources in their community if they're not sure where to start. We can provide education on things like support groups through places like Gilda's Club or Cancer Care or peer-to-peer support. If maybe they are not necessarily wanting to talk to a therapist, but they want to talk to somebody who's been there before. We can provide education on communication with family and friends. I get that a lot, especially like with parents of kids, teens who are just not sure how to talk about what this diagnosis is, what it might look like, how to communicate appropriately depending on your child's age. That's something that we can help with. Another thing that we often help with are crisis interventions. And so this can include things like suicide assessments, LCSWs and CSWs who are able to provide counseling are qualified mental health providers and so can complete suicide assessments, and then facilitating end-of-life conversations and being a part of that as well and offering that empathetic support. Next slide. So these are some of the sort of the middle of the Venn diagram of both practical and psychosocial resources that we often assist with. So I'll get into this a little bit in some of my later slides, but we respond to distress screenings, which is one of our primary ways that we receive consults at Markey. We can support patients through changes in employment through organizations like Retain Kentucky. We can facilitate communication between the patient and the care team. If the patient opens up to us about something they don't understand about their diagnosis or their treatment or something that they're just concerned about, we can sort of act as that liaison and provide guidance to new patients who are navigating, especially for us at Markey, this huge environment, and they might be really unfamiliar with it. We can complete psychosocial assessments for treatment. At Markey, oftentimes this looks like completing assessments for bone marrow transplants, but also, if there's a concern about social supports and assessing for that, we can complete those types of assessments as well. We can explore social support. Sometimes people might show up and be like, I don't have anybody, nobody's going to help me. And spending time with them to sort of explore, is it that no one's there to help you or that you are a little hesitant to ask for help? And what might it look like to ask for help? And then, of course, patient and family advocacy throughout the process. Next slide. So I'm going to just go through this super briefly because I'm not sure if you all use this or not. So at Markey, we use what is called a distress screener, and I'll have a little snippet of what one looks like a little later on. But essentially, this is one of our primary ways that we receive consults. But I think it's helpful just even as a framework to see what are all the types of things that social workers can help with. And admittedly, we do have some additional members of our team who help with some of those items. But that is one of the ways that we receive a lot of our referrals, our consults. So if you want to move to the next slide, it'll go into a little bit more of what the distress screener is. You can move to the next slide. Okay, great. So the distress thermometer, while it is a specific tool that we use, I think it's a good just sort of format for how to engage with and for social workers to receive consults. It's self-administered, so the patient identifies and marks for themselves what their concerns are, because sometimes it can be difficult to verbalize that, especially some of those items on there. They may not always feel comfortable bringing that up with anybody, honestly. And so sometimes it's helpful for us to bring it up with them. It uses non-stigmatizing language. It is evidence-based and reliable. It helps patients identify patients in need. And while it is helpful as a starting point, definitely it is also important for us to step in then as the social worker and sort of assess and use our own clinical observation to see where the needs are. So next slide. So this is just what our distress thermometer looks like. And I know it might be a little bit small for you all. So those are all of the types of things that we as social workers and can assess and offer support with. And so if you're ever wondering, like, what are the types of things that social workers help out with, this is a pretty good list. I will note there are a couple things on there that we do refer out. One, we are fortunate to have dietitians on our team. So if someone marks changes in eating, we refer to them. And then anything in the spiritual or religious concerns section, we are also fortunate enough to have a chaplain on our team. And so we refer to her just so we don't step outside of our scope. But that is something that certainly as social workers, we are comfortable engaging with our patients with. And if it gets to the point where maybe someone would feel more comfortable talking to a chaplain or their priest, referring to that as well. Next slide. So now looking at what we can do for our care team, because we're not here just for the patients, we're here for the team as well. So offering psychosocial and emotional support. We all know clinics can be stressful at times. So something that I'll often do is meeting with our team members after a particularly difficult day or a particularly complex situation and just sort of making sure, hey, do you need to debrief? Do you need to talk? Do you have questions? We support the multidisciplinary team to provide quality care to the whole person. We can coordinate, navigate communication with families and patients, so sort of acting again as that liaison. We can support coordination of resources to help the recommended treatment plans, because someone may be needing daily radiation and that's the recommendation, but they don't have transportation. That's a place we can step in. And then essentially just being responsive to the needs of our patients and our families. And again, similarly as well with nurse navigators, just being there and being able to maybe spend a little bit more time because we're all super busy, providers especially. And so if somebody needs to talk on the phone for a while or being able to support our care team in that way. Next slide. So now just moving into the last section of benefits of the social work team. So some of the research supported benefits of having a social worker as part of the team increase quality of life for our patients during their treatment and care. And utilization of healthy coping tools is shown to decrease symptoms of things like depression, anxiety, and symptoms of cancer and its treatment throughout the treatment process. It's also shown to utilization of these healthy coping tools shown to decrease experience of stress, which certainly I know that we all know long-term stress can certainly lead to a weakened immune system. So helping our patients not only identify healthy coping tools while they're in the midst of a diagnosis and treatment, but long-term, ongoing, how to help them moving forward. Fostering and coping and adapting to a cancer diagnosis, because it is a huge adaptation, and adapting to what does life look like now. That's something that we can help out with. And then finally, supporting our patient in their understanding of their diagnosis and treatment, because sometimes it is just very overwhelming, a lot to take in. And so again, meeting with our patients where they're at to help sort of navigate what this space looks like, make sense of it, identify what barriers are, what concerns are there, and how can we approach them, work through them, remove barriers, and how can we best help them. Next slide. So additionally, some benefits of social work for the patients and families in terms of emotional, mental, practical support and resource coordination. We can increase education about availability of resources. Like Sabrina said, they may have heard of things in their community, but they may not know how to access them. They, certainly have heard of the American Cancer Society, but may not know about things like the Hope Lodge or, WIG resources, that type of thing. We can empower patients throughout the treatment process. We can provide education regarding utilization of healthy coping tools, like I mentioned before, and especially even too, not only for the patient, but for the family and caregivers as well, because research has shown that comparing psychological distress of patients and their caregivers over time throughout treatment has really, it really shows to be sort of parallel. They're both experiencing similar amounts of stress. So it's really helpful and important to pay attention to both. Reduction of financial toxicity. This is a huge thing. So whether it be helping with insurance, helping through community resources to pay utility bills, it's just a very important place as well that we as social workers can step in, particularly because research is showing that a lot of our patients are struggling to pay for things like rent, mortgage, utilities, as a result of medical debt they may be incurring. We can offer increased availability of transportation resources through things like referrals to Medicaid, or coordination with places like American Cancer Society Road to Recovery. And then again, just offering resources and support to family and caregivers as well. Next slide. Benefits for the care team. We can help support positive outcomes for our patients, which we're all working toward. We can help increase patient compliance with treatment. Like I said earlier, we may want daily radiation for a patient, or we may need them here for multiple days in a row for an iodine treatment. And that might not be feasible without some of the resources that we can help connect them with. We can provide education on the impact of psychosocial, social, cultural, and spiritual factors that are all a part of the whole person that we're treating and ultimately have an impact on the outcomes of health. We can help staff navigate difficult conversations, which certainly do come up, and we can help build relationships with community resources. So if they know us, we know them. It just makes that connection all the easier. Next slide. And just briefly as well, some additional statistics, because I know that it all sounds great in theory, but I know statistics and research are helpful to back it up. So the City of Hope Comprehensive Cancer Care Center has demonstrated a connection between physical symptoms, social problems, and emotional responses. And essentially, again, it makes sense. Like when there's an emotional concern, it might manifest as a physical concern and vice versa. So it's so important that we're working together as a multidisciplinary team. And research has shown as well that health systems that provide counseling and support for psychosocial distress have reduced length of stay, hospitalizations, emergency department visits, physician office visits, and number of prescriptions. So all things that are helpful for all of us. Next slide. So again, this is something that is just helpful to reference. These are some of the resources that myself and my colleagues use frequently. I'm not going to go through all of them, but they're just helpful to have in your back pocket. Like Triage Cancer is one that I love and go to frequently because it provides information about things like insurance, SSDI, finances, legal questions in really easy to approach language. They offer videos in multiple languages, easy to read handouts. It's one of my favorite go-tos. All of these are really great. Cancer Care offers good support groups, things like that. So just helpful to reference if you're ever like ooh, what might be helpful? So next slide. And then I'm just ending with this quote from Iris Cohen Feinberg. The most important thing we do is to truly be present with people. We bring knowledge, skills, and compassion to actively listen in unique and dedicated ways, bear witness to people's physical and emotional pain without abandoning them, and provide a non-judgmental setting for people to share and struggle with their joys, regrets, fears, strengths, and weaknesses. And I really do feel like that encapsulates a lot of what we do as social workers, and particularly in the oncology role. So that is the end of my presentation. I don't think I have a specific slide, just like for questions and with my contact information, but certainly if anybody, of course, has any questions now, I'm happy to answer, or if you need my contact information, I can certainly pass that on as well, or have the team pass that on to you. So.
Thanks, Devin. I don't think we had any questions. Thank you very much for that presentation.
Absolutely.
Next up, to close out our presentation tonight, we're going to hear from Amy Stevens, the Oncology Nurse Navigator for TJ Regional Health, and from Beverly Knuckles, the Oncology Social Worker with TJ as well. So I'll leave it to them.
Thanks again for everyone attending this evening. My name is Beverly Knuckles, and I am the social worker in oncology here at TJ Samson. Amy Stevens and I do work closely together. My role as a social worker in oncology is to talk with the patients. Initially, they will fill out a distress thermometer, and I do have some copies of information back there on the table along with my card. What we do, the patient will fill out that distress thermometer. They'll check off information that is pertinent to them, whether it's transportation, emotional distress, such as nervousness or fatigue, or a lot of different areas on that distress thermometer that patient will check off. And I like to go in and just talk to them, inform them of what I do, tell them that we're here for not only them, but for their families as well. I like to make sure that they know that there are resources available in the counties in which they live, whether that be someone to come in for companion care, whether they need assistance with transportation, whether they need additional counseling services, or they just may need a listening ear. And that's what I am too. I'm there to talk with them every time they come in to visit our clinic. I like to talk with them each time they're taking their treatment. If I happen to miss them on that day, I will make a phone call just to check in. Sometimes they just want to talk to someone, and that's what I'm here for as well. And we do give lots of resources to patients. I like to follow them through their care, even through survivorship. Melanie lets me know when she is formulating a care plan for that individual, because those things change. If that person is employed, I always make sure that they talk to their employer to see what kind of benefits that they can get from their workplace. So they may need some additional financial assistance. Could be Social Security disability. I give them that information. That's what I'm there for. I'm there to serve them in any capacity that I can. We have financial resources here in this organization. I may refer them to our financial counselor, but we want them to feel like they're not alone. Wherever they are in their journey, that's where we want to be with them. We are glad to answer any questions, any concerns. And I may say we do have a great group of people that we work with within the TJ Samson organization. So there's always someone available to answer questions, to hold their hand, and just to make sure that they know someone is with them through this journey. So that is part of my role. And as I said, I work closely with Amy Stevens, and I will just hand it over to her at this point. Thank you.
So yes, I am Amy Stevens, and as Beverly said, we work very closely together. I'm the Oncology Nurse Navigator. I've been in oncology for over 20 years. 15 of those years, I was a chemo nurse, and that really gave me the opportunity to learn and listen exactly what are the issues that our patients face. So I feel like my point of entry to them is upon diagnosis, and I follow them through survivorship, end of life care, wherever and I am whatever they need me to be. So it could be resources for education, it could be resources for financial, transportation, emotional support, coordinating appointments, whatever it may be. I am, like Beverly, here to be whatever they need me to be. To access me, most of the time right now, I am in medical oncology. That's when I enter the picture. What I would like is right when they're diagnosed. If you want me to come to the hospital, see your patient, I would love to come talk to them, as soon as they're diagnosed. Dr. Serdakis sometimes makes referrals, other surgeons, I get patients that way. I also get them through tumor board, like I mentioned. There's not really an official referral process for navigation at TJ right now with the new system. They're working on that. So for now, I think Melanie mentioned there is an other that you can choose. Is that right, Melanie?
If you click other, then it gives you a free text. I think right now that's what we're going to utilize.
So you can put it there. It will go to our scheduling, and then they alert me. You can call me. 9 times out of 10, I am in the oncology department. I have my contact information in the back. You can halo me. I don't care. Whatever is easiest for you. And I'll be glad. Like I said, I pick up a lot of patients. I'm going to pick them up if they come to medical oncology. But if they don't, if they're surgery only, or if they're radiation, then I may or may not pick them up. It depends. But if you want me to, I certainly want to, because I feel like there's a population of people that I don't get to. And even though medical oncology patients have a lot of needs because their active treatment could be months or years, I feel like I am serving a group that is very much in need. But I feel like some of the others, even if just surgery, maybe they have no idea about mastectomy supplies, or where to go, or how to access it, or whatever it may be. If I can get to them, the sooner I can get to them, the better. So even if it's just to help them with some anxiety and assure them it's okay, that it's been a month since your surgery and you haven't started treatment, or because that's a very overwhelming and anxious time for them, the waiting and not knowing, and it's all overwhelming. But so however, I tell them all the time, I certainly don't have all the answers, but I will do anything I can to help you find them. So does anybody have any questions about navigation?